But the thing is that last time I didn't tell you to go around. The thing is you look at your eyes. The other way was the eyes. If I just don't put it on the okay? All right, g'day guys. Sorry about it being so late and like on a Friday evening. We'll try and like get through and then we can see what the time is and like if it's all right, we'll do some questions at the end, and if not, you can have them and we'll go home. We'll start off with this. Like, there's not a lot you need to know of this diagram, but it kind of gives a good overview for all of hematology, given that it kind of shows you everything. So it's worth knowing that lymphocytes come from a lymphoid progenitor and everything else comes from a myeloid progenitor. So kind of split those into your mind, because I always thought it was red cells here and white cells there, which is just wrong. Going on from that, this is a full blood count, and it's like you'll see at most hospitals. And the things you really care about here are particularly hemoglobin. So how much are they anemic? Are they polycythemic? Is it normal? If you do have an abnormality in the hemoglobin, you then look at the median corpuscular volume. So that tells you how big the red cells are. And so that helps you define it into if it's a microcytosis, a normocytosis, or a macrocytosis. So whether they're decreased, normal, or increased. And the range is usually given, but it's about 80 to 96. It should be given you an exam if you're given actual values. Then you look at the white cell count. So is it normal, is it elevated, and each of the individual counts. And then, yeah, so lymphocytes come from the lymphoid progenitor cells, and they take into account B cells and T cells. Everything else is myeloid. And they've all got different things they react to, but you don't really need to know that much about them. Not for hematology, more for immunology. Okay, so red blood cells come from the common myeloid progenitor. So I'm just getting rid of the glare. And they're flat, they're anucleate, and they've got a biconcave disc shape. So that's to help them get through capillaries. They're made up of 4 globular proteins. So adult hemoglobin, hemoglobin A, it's called, it is made up of 2 alpha subunits, 2 beta subunits. So here we've got 2 alpha chains, 2 beta chains, and then right in here we've got a little heme molecule with a iron suspended within it, and that iron is actually what binds to the oxygen. So there are also other types which exist in lower levels in the body, and it's important to know about them because they're what's altered or changed when things go wrong. So hemoglobin A2 is made up of 2 alpha and 2 delta subunits, and it normally exists at less than 4%. Fetal hemoglobin is 2 alpha and 2 gamma subunits, and it's the majority of hemoglobin in the fetus, but it's eradicated 7 to 8 months after birth. And it also has a lower affinity to 2,3-DPG, and so it has a higher affinity for oxygen. I think I've given away one of the answers to the question. Each globular protein has one, yeah, so we've talked about that. Also, the iron molecule, the ion binds to carbon dioxide or carbon monoxide if the hemoglobin is carrying that around. So this is kind of the basic hemoglobin chart for a baby. So what you see is it starts off being made in the yak, so the liver, the spleen, and then the bone marrow predominantly in adult life. And your levels of alpha chain are always quite high because alpha is involved in all your hemoglobin. Your gamma starts off high and then dips down after birth. Your beta increases after birth. And your delta, remember we talked about, like, that's just at 4% roughly, so that comes up a little bit. Epsilon and zeta to do with a pre-fetal hemoglobin, and they're not around when you can detect it. So the majority of adult hemoglobin is made in the bone marrow. So the tibia and femur, they stop at about 25. Ribs, sternum, and vertebrae all continue making throughout life, and the ribs break off a bit before the sternum, and then the vertebrae do the majority of production in over 65s. It's all induced by erythropoietin, or EPO, which is made 90% in the kidneys and 10% in the liver. Red blood cells live for 100 days. If you have kidney failure, so the primary method of anemia and kidney failure is due to decreased EPO. The liver increases the amount it makes a little bit, but not a huge amount. So in renal failure, that's why you get anemia. And so this is, I think you did this with REST and you did this in first year as well, but it's the oxygen hemoglobin dissociation curve. It's really important to know. So A left shift means a lower oxygen concentration in the blood is required for an equal hemoglobin saturation, and a right shift means a higher oxygen concentration is required. Tissue has a higher temperature, it's more acidic, particularly muscle tissue. If you think about it like moving, creating energy, it's going to create heat as a byproduct. And anaerobic respiration creates lactate, which is an acid, so it's more acidic, creates an environment favorable for oxygen unloading. The lungs are the opposite, it allows oxygen to bind. Hemoglobin's affinity to oxygen is increased by binding O2. So what that means is instead of having all your hemoglobins, and then when you get to 25% saturation, each of those hemoglobins has one oxygen attached to it. If you get one hemoglobin which has one oxygen attached, that's going to preferentially take up the other 3 oxygen. So hemoglobin saturation of 75% means 75% of your hemoglobin molecules are fully saturated, and the others tend to have nothing. That's important when it comes to carbon monoxide poisoning, because carbon monoxide binds to hemoglobin much more strongly than oxygen at roughly 200 times. It also alters the shape of the hemoglobin. So what you get is you get 3 oxygens and 1 carbon monoxide attached to a hemoglobin, and the way the carbon monoxide alters the shape means that those oxygens can't be unloaded. So you get oxygen trapping in hemoglobin with carbon monoxide poisoning. Only other thing I wanted to mention here was the S shape of the curve. What that means is if you get a patient who goes to 80% saturation, the difference between 80% and 100%, if in terms of pressure, is 50 and 100 millimeters mercury. So if you go from 50 to 100 again, you're down to 0%. So when you get to this the steepest part of the curve, hemoglobin saturation is very prone to change. It's very dangerous. That's why you want to keep patients above it. So yeah, question 1, fetal hemoglobin displays a resistance to 2,3-DPG. In regards to the oxygen hemoglobin dissociation curve of normal hemoglobin, fetal hemoglobin will display a, I'm going to point to someone, and then for the next question, they're going to choose someone to answer. So you can answer this one. Yeah, A. So I think I discussed that earlier. So left shift means it binds hemoglobin more tightly, and that's so it can actually deliver it properly throughout the tissue. Because if you think about it, the fetal and maternal, the fetal blood supply needs to get oxygen. And so it needs to better to perfuse that. That can't be lost to the mother's tissue. Yeah. Anemia. So there's low levels of hemoglobin. Normal levels. Okay. Anemia is because of low levels of hemoglobin in blood. For males, it's less than 130 grams per litre, and females, it's 115 grams per litre. So like I said before, an anemia can be micro, normal, or macrocytic, and that indicates the average size of the red blood cells. It can also be hyperchromic, normochromic, or hyperchromic. No one actually cares about that. The classic thing is iron deficiency is described as a microcytic hypochromic anemia, but apart from that, no one actually cares about the color until you get to hematologist level. There's plenty of, it's not actually a diagnosis. You actually need to work out the cause, and it can be further classified as hypo or hyperproliferative. So it means, is the bone marrow making enough red blood cells? So if it's making more red blood, so if you've got low hemoglobin and the marrow is making more red blood cells, then that's good. It means the marrow is working properly. It means there's just a problem with destruction. If you've got low hemoglobin and low production of red blood cells, it means the marrow is failing for some reason. And so because of that, we look at the reticulocyte count in an anemia we're investigating, and that's often the best marker of red blood cell production and therefore bone marrow health. So symptoms like dyspnea, particularly on exertion, fatigue, dizziness, angina, when coronary artery disease already exists. You can imagine if you've already got decreased blood flow and you decrease the hemoglobin, there's going to be decreased oxygen. You can have palpitations. It's often an incidental finding, like an old lady presents to hospital, half of them have anemia just because of poor diet. Signs, so you get conjunctival pallor when you pull down the eyelids, pallor of palmar creases, so when you stretch back, the creases of your hands aren't red, they're white, and tachycardia as well. You've got a decreased oxygen delivery to the body, so your heart pumps faster to get an increased cardiac output. So the three acronyms I remember: TAILS, HIBRA, and ABCDEFL. So for microcytic, it's TAILS, so thalassaemia, anemia of chronic disease, iron deficiency, lead poisoning, and sideroblastic anemia. The two I've bolded are the ones you're most likely to be tested on. They're most likely to occur. Normocytic, so HIBRA, is Haemolytic Anaemia, and there's further subtypes which we'll go into. Infiltrative, so that could be aplastic anemia, or could be anything that's going into the bone marrow and replacing it. If you're bleeding, so if in an acute bleed, once the patient's been fluid resuscitated, so not when you pick up someone off the street with a knife wound and they've been bleeding and you take their hemoglobin, their hemoglobin's still going to be normal. Once you get IV fluid, so like saline or Hartmann's into them, then because their blood dilutes, that's when you get a normocytic bleed anemia. Also because of renal failure and anemia of chronic disease. Again, macrocytic is alcoholism, B12, a compensatory. So after a bleed, you get a compensation in the days after, which involves a macrocytic anemia. Dysplasia, or drugs like azathioprine or cytotoxic drugs. Endocrine disorders, so hypothyroidism causes a macrocytic anemia. Folate deficiency and liver disease. So I'll start with thalassaemia. It's because of an abnormal production of a globin chain, so those alpha and beta chains we looked at earlier. It's autosomal recessive and has an alpha and beta form. Beta is more common. It's also more, because alpha is, you have 4 alleles for alpha chain synthesis, so the effect's diluted. So alpha is more common in Southeast Asians, A and A. Beta is more common in Mediterraneans and Greeks. And the Monash exam question on thalassaemia will always mention they come from a Mediterranean background. So 2 alleles affect beta chain synthesis, and they can be affected by a defect or a deletion mutation. So 1 gene defect, so 1 beta gene is normal, 1 beta gene is deleted, or 1 beta gene is normal, 1 beta gene is mutated. So 0 deletion plus this mutation. It's mostly asymptomatic. It occasionally is an incidental finding with a little bit of anemia, or you might get like it's incidental usually. You can get 2 gene defects, so 1 or no deletions, so deletion and a mutation, or 2 mutations, and that's moderate anemia and corresponding symptoms. With 2 deletions, so if you can't create any beta globin chains, you get severe anemia, a splenomegaly, and a failure to grow and thrive. And this is all investigated by hemoglobin electrophoresis. So you separate out and you work out how much of each type of hemoglobin you have, because obviously if beta chain hemoglobin is affected, that you get increased levels of, particularly, occasionally you can get fetal hemoglobin, mostly you get increased delta hemoglobin. Okay, and each human normally carries 4 functional alpha genes, AAs-AA. The only important thing to know about, it's hugely unlikely that this will come up, but alpha thalassaemia is possible to have a deletion mutation in all 4 genes, and that's incompatible with extrauterine life. So once the baby's born, they die fairly quickly after. That's because they can't produce human hemoglobin. They can only produce that zeta-eta type stuff. So for beta thalassaemia, it's hemoglobin electrophoresis. For alpha thalassaemia, it has to be investigated by DNA PCR. It's a low hemoglobin MCV, but the MCV decrease is usually more than the hemoglobin increase. And an X-ray of the skull, it almost looks like in the actual skull bone, it looks like there's hairs on end. That's kind of a pathognomic finding, but no one does an X-ray of a skull because you'd just be using it to confirm a diagnosis of beta hemoglobin, beta thalassaemia, which you do with HB electrophoresis. So it's just not done. Blood films, you can see target cells and teardrop cells. I'm studies Oh, you do an iron studies in beta thalassemia, intermediate or major, because you can get iron overload in them. Treatment is symptomatic, so you don't treat if there's mild anemia with no symptoms. You can get regular blood transfusions in beta thalassemia major because they need them to stay alive, and intermediate, depending on severity. Maybe if they're going into surgery, you'd give them a blood transfusion beforehand and have extra blood on hand. Haemochromatosis can occur as a side effect due to they actually get increased iron absorption in the gut because the body's trying to compensate by making more hemoglobin. It doesn't really realize that it's not able to do. So yeah, ineffective erythropoiesis. So it's not able to make hemoglobin as quickly, so that iron builds up. And also in beta thal major, you get multiple blood transfusions, so that iron builds up in the body. And that is treated in thalassemia's case with iron chelation therapy, so desferrioxamine. Iron, sorry, a bit of a tickle. Iron deficiency anemia is the most common cause of anemia universally. It's also not a diagnosis. There's always a secondary cause, and it can be due to decreased absorption or increased loss. Really importantly, maybe not this year, but clinically, 95% of iron deficiency anemias in postmenopausal women and all men are due to GI bleeds. 90% of iron deficiency anemias in the over 65s are due to colorectal carcinoma. So something as a management plan for iron deficiency anemia, you always say scopes. That's just a tip, which is important. Dietary insufficiency, so vegetarians and vegans. There's also the fact that people who don't eat meat don't have access to heme iron, which is better absorbed in the body. Chronic blood loss, so a GI bleed, heavy period, repeated blood nose. You can get poor absorption in the duodenum, which is where iron is absorbed, in celiac, in a gastrectomy, or in Crohn's disease, affecting the duodenum. And signs, you get concave nails called koilonychia, glossitis, and angiocheilitis. So glossitis is swelling of the tongue, and angiocheilitis is, I don't know how to say it properly, it's inflammation of the corners of your mouth. It's fairly specific, actually. I didn't realize that. Hemoglobin and MCV tend to decrease by the same amounts. You also do an iron studies to confirm it. Blood film, you see your microcytic hypochromic anemia. You also might see target and pencil cells. And scopes, you only don't if it's, for example, a 25-year-old woman with very heavy periods, which then corrects once you give oral iron. So yeah, treatment, oral iron's usually first line, but they're GI side effects. So you can give an iron infusion instead in malabsorption syndromes because an iron infusion is given IV. Post-gastric surgery or with severe ongoing blood loss, or if they can't tolerate GI side effects, some people are particularly susceptible, and blood transfusion if it's severe and symptomatic. So usually less than 80, hemoglobin less than 80 is when we transfuse. Normocytic anemia, you differentiate based on a reticulocyte. Oh, if there are any questions at any stage, just like put your hands up or shout out, because I'm going to try and go quickly so we're not here too long. So yeah, just ask. Normocytic anemia, we differentiate on a reticulocyte count, so it can be hyper or hypoproliferative. Going back to the HIBRA, so blood loss is, well, initially it won't be either, but once you start to hemodilate, give it a few hours, then it becomes hyperproliferative. Hemolysis or hemolytic anemia, unless there's an underlying bone marrow disorder, will also be hyperproliferative. Hypoproliferative normocytic anemias are aplastic anemia, renal disease, chronic disease, so anemia of chronic disease. With lots of inflammation, liver produces hepcidin, which causes the iron to be stored in cells. Like, this is because iron is used by some bacteria to multiply. It's actually a survival benefit, but it's more of a concern in autoimmune conditions, which cause like lots of inflammation, and there are no bacteria to kill by withdrawing their iron supply. Haemolytic anemia, so GMASH, so we've got G6PD deficiency, microangiopathic hemolytic anemia, autoimmune hemolytic anemia, which can be warm or cold, sickle cell anemia, and hereditary spherocytosis. So G6PD is an excellent recessive genetic defect. It's more common in people with Mediterranean African ancestry and in males, and it occurs in response to certain triggers, so it's not normally there. The classic trigger is fava bean, so it's occasionally called fava anemia or something along those lines. Infections can cause G6PD to become anemia, or drugs or toxins. So particularly those derived from quinine, so anti-malarial drugs, and isoniazid, which is one of your TB drugs. On your blood film, you see Heinz bodies and bite cells, which are the buzzwords for them. Something I didn't mention is like heme is usually pretty easy because it's fairly buzzwordy. Just remember your buzzwords and you're going to do fine in the exam. In certain systemic diseases, so microangiopathic is fairly dangerous, also fairly unlikely to be tested because it's quite complex. But when you get endothelial damage, fibrin platelet clots form, kind of like an atherosclerosis, but not everywhere. And they narrow the vessel's lumen, and literally blood cells are ripped apart as they go through them, which produces schistocytes, which is a schistocyte is a fragmented part of a red blood cell. It occurs in a lot of things, so haemolytic anaemic syndrome, disseminated intravascular coagulations, TTP, malignant hypertension, SLE, and some cancers. That's all you really need to know, just like a baseline of it. Autoimmune haemolytic anemia, so it's more common in women. It can be due to another autoimmune disease, an infection, or drugs. Half the cases are idiopathic. So a positive direct Coombs test is diagnostic, and warm type occurs at 37 degrees or above. Cold type occurs at 28 to 31 degrees. What's important there is you only see cold type presenting in the winter, or when they've been somewhere particularly cold, or when it's an elderly patient who's not able to maintain their body temperature as well. So investigations, Coombs test, I need to add that on. And you also have a high titer of serum cold agglutinins in cold subtype. And on your blood film, you see spherocytes. And we'll keep hitting shift. So direct and indirect Coombs tests. I don't really want to go into the details of them. Your lecturer probably did that better than I can. But direct Coombs test for an autoimmune haemolytic anemia usually, and it's testing your own immunity to your blood. An indirect Coombs test is used for cross-matching. So you use the recipient serum and the donor blood, you mix them together, and you see, do they react, do they agglutinate? Because if they do, then that's going to cause intravascular hemolysis if you give that blood as a transfusion. So a positive indirect Coombs test means you can't transfuse, negative means you can. Any questions on that? No. All right. Sickle cell anemia. So it's an autosomal recessive condition. It results in sickle-shaped red blood cells. It's an abnormality 6 amino acid code on the gene for the beta-globin subunit, where glutamic acid is substituted for valine. It results in a sticky patch in the hemoglobin unit, which it changes its tertiary shape. It's most common in sub-Saharan Africans. It confers a survival benefit against malaria, and it results in hyposplenism because you infarct your spleen in childhood. This is because like the sickle cell they kind of clog up blood vessels because they're not shaped properly. So you can get little microinfarcts, particularly in the spleen where it's filtering a lot of them. And those microinfarcts build up and cause a non-surgical hyposplenism. So on your blood film, you see sickle-shaped cells and Hal Jolly bodies. Hal Jolly bodies can also be seen in any type of asplenism. They're just little DNA inclusions in a red blood cell, and you get them because you don't have the spleen to pull out the cell out of circulation. Hereditary spherocytosis, so common in autoimmune haemolytic anemia. But hereditary spherocytosis is when a genetic defect causes them to appear in the blood. It's an autosomal dominant condition, and the spherocytes, sorry about the spelling, they're small and spherical, and they're easily ruptured in transit through the spleen. It's more common in people of Northern European ancestry, and the treatment is a splenectomy, so you remove the causative agents of the hemolysis. On the blood film, you see spherocytes because it's hereditary spherocytosis. Aplastic anemia. So to be diagnosed with aplastic anemia, we've moved on from hemolytics just onto other normocytics now. Defined as a pancytopenia, so usually anemia, leukopenia, so decrease in one of the white blood cell types, and thrombocytopenia. And it's usually due to injury and dysfunction of the pluripotent stem cell. So there are a bunch of things that can cause these cytotoxic drugs and radiation in particular. Drug reaction, toxic chemicals, benzene is a buzzword. I should bold that. Viral disorders, immune disorders, miscellaneous, genetic. On the blood film, you see pancytopenia and decreased reticulocytes because the bone marrow reacting properly, it's not actually producing the red blood cells. In B12 and folate deficiency, you get a megaloblastic anemia. Megaloblastic is pathognomonic of B12 and folate. So it doesn't just mean they're macrocytic, it refers to nucleated red blood cells, which are oddly shaped. And that's because they're not formed properly. So they're almost as big as neutrophils on blood films. And this is because like B12 and folate are involved in DNA synthesis. So you also get hypersegmented neutrophils. B12 deficiency can cause an irreversible peripheral neuropathy and prolonged deficiency in addition to anemia. So if someone is B12 deficient, but if you give them folate supplements or adequately increase their folate, then that anemia is going to disappear. But that B12 will still be low and it will still cause its peripheral neuropathies, which are long-term and irreversible. So you always resupply B12 and folate at the same time. You give them both. And I'm pretty sure we had a question on folate and B12 deficiency. B12 is absorbed in the terminal ileum. It's used intrinsic factors required for absorption. So when you have a lack of intrinsic factor, it's called pernicious anemia. That's another autoimmune condition. There's 3 to 5 years stored in the liver. So if someone comes in vegan and they've been a vegan for 6 months, it's unlikely to be a B12 deficiency. And so they might use that to trick you out in an exam. It's replaced iron as hydroxycobalamin. It can be deficient due to Crohn's, pernicious anemia, or a vegan diet. It's found in meat products and dirt, but it can be supplemented from bacterial B12 or something. Folate is absorbed in the jejunum. It's found in green leafy vegetables, and we don't have any storage for it. So 2 to 3 weeks, and you are folate deficient. You get deficiency in malnutrition, Crohn's, celiac, pregnancy, and methotrexate. So someone on rheumatoid who forgets to take their folic acid supplements will get a megaloblastic anemia. All right, so what's not true about the direct Coombs test? I got you to answer, so name someone to answer. I'll give you a moment to read it. Yeah, D. So it's a bit of a dickhead question, but it's used for cross-matching recipients, plasma and donor blood. The other ones are, so complement's an inflammatory marker. It's positive in hemolytic disease because of the rhesus factor, and it detects agglutination of antibody-coated red cells. Those are all true. So this is just a narky wording one, but I also wanted to teach you that it may become positive if there's a little bit of complement, so in inflammation. That's why we use more advanced ABO typing nowadays. So this is the basic ABO type. If you're group A, then in your plasma you'll have anti-B. If you're group B, you'll have anti-A. If you're group AB, you'll have no antibodies. And if you're group O, you have antibodies to everything. I don't want to go through this. I'm sure you've done it all to death. So transfusion characteristics. So antibodies for ABO grouping are IgM, and so they cause an immediate reaction. Rhesus antibodies, there's 50 types. When we talk about rhesus, we mean rhesus D. 85% are rhesus D positive, and the antibodies to them are IgG and therefore can cross the placenta, which is the important thing because it results in hemolytic disease of the newborn. So this is when you have a rhesus negative mother and a rhesus positive child. And during birth, or like say a wrong transfusion, the mother is exposed to a child's rhesus-positive blood and develops anti-rhesus antibodies. And during the mother's second pregnancy with a rhesus-positive baby, the IgG antibodies cross the placenta and adhere to the fetus's RBCs, causing hemolysis. It's fairly severe and warrants treatment, but it also gets worse with each successive pregnancy if you don't contract it. So what we do is we give anti-D we give it at 28 weeks, but most importantly, we give it at birth of their rhesus-positive children. So what that does is it destroys the rhesus-positive cells before the mother can develop an immune response against them, and that prevents the mother from being sensitized, which prevents the baby from developing hemolytic disease in the newborn. Also, you can get an ABO type. It's usually mild because, like, some people can form IgAB antibodies. You're not going to be tested on it. It's just really interesting, actually. Sorry, I just put in a bunch of stuff that I find interesting. Transfusion, so cross-match and group and hold is a clinical difference. So cross-match you do if you actually know you want 2 units. Group and hold you might do because someone's going into knee surgery and they might need a transfusion, they might not. You just want the blood to be ready if you do. So it's grouped and tested against other blood samples to ensure compatibility so that units of blood are available for transfusion. It also ensures that, like, all those 50 minor different rhesus antibodies are actually compatible within the people as well. So even though we only think about, like, the major blood groups, and in an emergency, as long as it adheres to those major blood groups, ABO, positive, negative, you're going to be okay. For cross-match or transfusion, they do really specific typing to make sure that blood is as close to perfect for you as it can. It's checked with an indirect Coombs test, and so I think I just talked about that. What's not true about serum iron? You get to name someone. Right up there then, I think, once you've read it. Yeah, D. So it's transferred in plasma by transferrin. Ferritin's actually, what happens is ferritin's a protein that's used to store iron in cells, so it kind of creates a capsule around it, and when you create those capsules, some ferritin leaks out into the blood. So when there's increased capsule because we've got increased iron storage in cells, then there's an increased circulating ferritin level. Yeah, so serum iron is the unbound serum iron. Ferritin's iron storage. Transferrin is an iron transporter protein, and the total iron binding capacity is propensity for iron to bind. You actually care about these in decreasing levels. So serum ions, it changes throughout the day. It's not actually that accurate. Ferritin's an acute phase reactant. It goes up with inflammation. That's important to know, but it also means that if someone's inflamed and you think they're anemic, you can't actually look at their ferritin. Transferrin's also an acute phase reactant. So it's not, you don't have to know about transferrin total iron binding capacity. So transferrin is an acute phase reactant. You don't need to know that till next year. Total iron binding capacity is actually the most accurate of all of them. But what we expect to see is, assuming you capture everything at the perfect moment, in iron deficiency, you have decreased iron, decreased ferritin, but increased transferrin and total iron body TIBC. In hemochromatosis, you have increased serum iron, increased ferritin, decreased transferrin, and decreased TIBC. And in anemia of chronic disease, you have decreased serum iron, increased ferritin, but decreased transferrin and TIBC. Cool. In which of these conditions is iron absorption favored? You get to name someone. I'll give you the possible A. So in iron overload, obviously it's not favored. Chronic inflammation, your body doesn't want iron. It's still thinking it's fighting off bacteria, and iron's good for a lot of bacteria to multiply. Increased dietary phosphate. Phosphate's a negative ion. It's an anion, and so it binds with iron in the gut and is excreted as iron phosphate. That also happens with calcium phosphate as well. So hemochromatosis, it's a congenital or an acquired condition in which too much iron is stored in the body. All of the excess iron deposits in organs, which causes damage. So liver, heart, testes, pancreas, and brain. The symptoms are bronze diabetes. So you get hyperpigmented skin and diabetes because of the pancreas damage. You get joint pain, cardiac problems. The diagnosis, so iron studies, you get a high ferritin and a low transferrin and total iron binding capacity. And you can also do a genetic test in individuals with a family history because it can be congenital as well as acquired. So treatment, if it's not due to thalassaemia, you do regular venesection, so drain blood. If it is, or if venesection is inadequate, you can use iron chelators. So like I said before, desferrioxamine. I think I'm saying that right. I don't know. Hematological malignancies. So you've got your myeloproliferative and your lymphoproliferative. These aren't all of them, obviously, but they're all you need to know for this level, unless the teaching's changed, in which case you're going to have to learn some extra stuff. CML, Polycythaemia, we can talk about all of them. What matters is there's 4 types of basic myeloproliferative, and they can all progress to these secondary ones. I think AML is the only one that can actually present by itself. And I like this graph because it actually shows you where all of them come from. So essential thrombocytosis is a problem with the thrombocytes, PRV, erythrocytes. AML comes from the myeloblasts, and there's actually a few steps in between, and that's where CML comes from. ALL comes from immature lymphocytes, and then B and T lymphocytes form your CLL, and then plasma cells form multiple myeloma. I like all my notes from last year are sort of like based off this graph because it puts it all in context, tells you where these cells were in their progression when they began. So it just makes it a little bit more altogether. So polycythemia means extra red blood cells, and primary can be because of polycythemia rubra. Secondary can be because you're living at a high altitude or altitude training, COPD, or increased EPO from doping or renal cell carcinoma. PRV is most common in adults above 60. It's usually due to a JAK2 mutations in 95%. That's buzzworthy. Even 12M in 4%. Unlikely. It's usually JAK2 that they test. The classic symptom is pruritus, so itching after a hot shower. You can get plethoric skin, headache, burning, pain, paresthesia in hands or feet. There's an increased thrombotic risk, so you get an increased risk of MI, strokes, DVT, and you can manage symptomatically with venesection, and you use aspirin prophylactically because of that increased thrombotic risk. Essential thrombocytosis is too many platelets. So adults above 50 is who you're worried about, and half of ET cases are due to a JAK2 mutation as well. You get spontaneous clotting, and once you start getting that spontaneous clotting, it eventually leads to consumption of all the clotting factors. You then get bleeding. It's kind of like what happens in DIC. So you can get headache, visual disturbances, embolic events, so MI, stroke, DVT, finger ischemia, and bleeding. Who knows what the finger ischemia is from? It's actually due because like clots form and then are flicked off into the arterial system, into the fingers. It can be into the toes. It's rarely to the legs because the clots aren't big enough. On peripheral blood smear, you can see how Joel body's excess platelets and megakaryocytes. So we talked about here, these are your megakaryocytes. They're ejected into the blood in essential thrombocytosis. Now you manage it with aspirin and hydroxyurea. Aspirin because of the thrombotic risk, hydroxyurea is cytoreductive, so it reduces synthesis of DNA. And then you've got primary myelofibrosis, which often comes from ET or PRV, and it's excessive production of fibroblast growth factor. So because of all the inflammatory markers released by the PRV or ET process, you get like lots of collagenation. So you get fibrosis of your bone marrow, which eventually becomes unable to produce the right amount. So that's why, like PRV event, you start off majority with too many red blood cells, but eventually it can drop down into anemia. So you get your B symptoms, and they're referred to a lot in hematology. Your B symptoms are fever, malaise, and night sweats. They're classically associated with Hodgkin's lymphoma, but they appear in a lot of other things. You also get massive splenomegaly and increased infections and bleeding because of decreased white blood cells and decreased platelets. On your peripheral blood smear, you see teardrop cells, and you can manage with hydroxyurea early. So that's because of, like we saw here, for essential thrombocytosis and PRV, you want to decrease that over creation of one specific cell lineage and bone marrow transplant. So eventually you just nuke their bone marrow and give them a new one. That's a refractory treatment. Like, it's super dangerous. Yeah? Oh, so they're referred to as B symptoms. There used to be A symptoms and C symptoms and D symptoms. They're not. Those classifications don't really exist anymore. B symptoms just means fever, malaise, night sweats. It's just a name for that grouping of symptoms. All right, so CML is adults aged 40 to 60. It results in a translocation from chromosome 9 to 22 to form the Philadelphia chromosome, and it results in a BCR-ABL fusion oncogene. Super buzzwordy, always gets tested, like always. Eukaryotypes, there's 3 phases. There's a chronic phase, which is treatable with imatinib, an accelerated phase, and a blast phase. So blast phase is when your blast in bone marrow exceed 20%. 2/3 of them behave like AML, and 1/3 behave like ALL. It's usually AML though. So you kind of think of it as progressing into AML. Its symptoms are similar to other leukemias. So you get weight loss, abdo pain, itching, and your B symptoms. So night sweats, malaise, and fever. And you can also get massive splenomegaly. So it's one of the 3 causes of massive splenomegaly. Does anyone know the other 2? Just shout them out. Yeah, so it's myelofibrosis and malaria are the other classic ones. Like, you can get other ones, but those are the classic ones. You manage it in the chronic phase with a tyrosine kinase inhibitor, and I'm sure your lecturer talks about imatinib and how new and fantastic it was, and how it's actually like 20 years old now. AML is most common in adults 40 to 60, but can occur in all age groups. It's a myeloproliferative neoplasms can evolve into AML, and it's fairly poor prognosis, as AML is fairly aggressive. You get anemia, increased infections, increased bleeding, bruising, lymphadenopathy, hepatosplenomegaly. You can also get gum hypertrophy. That's a bit of a buzzwordy one, DRC, and fever. In your peripheral blood smear, you see ORODs. We had a question on that last year in the white blood cell cytoplasm, and more than 20% blasts on your bone marrow biopsy. Flow cytometry shows CD33 and CD13. But with chemotherapy, 30 to 40% of them actually go into regression. That's not lifelong regression, but I think like 20 or 30% of them maintain lifelong regression and eventually die from something else. CLL is adults 60 to 80 years. It's higher in males, so more common in males. It's the most common type of leukemia in adults. The symptoms are lymphadenopathy, hepatosplenomegaly, but also it's often asymptomatic. So you find like a 70, 80-year-old who might be getting a little bit more tired. They might not be, but they come into a GP and are diagnosed with CLL. So flow cytometry, CD19, CD15, I think it's CD29. I couldn't read my notes. It could be 27 or 21. I'm pretty sure it's 29. Maybe look that one up. It can also be due to deletion mutation. in 17p. On your peripheral blood smear, you see smear or smudge cells because they're like kind of fragile, because like they're being made too much, they're not being made properly. So when you smear them out, they smudge. So you manage them with chemo. A third never progress, and then a third progress to like a B-cell lymphoma, which is a little bit more aggressive, not that bad. Usually you just watch and wait. And then a third can actively progress, so they can undergo Richter's transformation to diffuse large B-cell lymphoma or into B-cell promyelocystic leukemia. I think it's promyelocytic. Yeah. Sorry about the spelling. Richter's transformation is the big buzzwordy one that it might be worth remembering. ALL, it's common in children and elderly. There's a T cell and a B cell type. Sort of symptoms are testicular enlargement, fever, bruising, bone pain. 70% cure rate in children. It's a lot less in elderly. That's all you need to know about. It's buzzwordy. It's not really talked about with Monash. Multiple myeloma is super interesting. So it's a neoplasm of the plasma cells. So all the plasma cells stay in your bone marrow, and they're actually what produce your antibodies. So you get usually a huge increase of, it can be IgM most of the time. It can also be IgG. I don't think it can be IgA, or if it is, it's very rare. And then you can also get production of just light chains, or just heavy chains, or just like sort of chains everywhere. Your symptoms are CRAB, so hypercalcemia, renal failure, anemia, and bone pain. It causes lytic bone lesions, so you get a collection of plasma cells in the bone which sort of dissolve it all out, so particularly in the spine, because multiple myeloma is a disease of the elderly. And like I said before, most of your active bone marrow in the elderly is in the vertebrae. So you get lytic bone lesions because it dissolves out into those bones. And because that bone is dissolved, it causes calcium to go out into the blood, so you get hypercalcemia. FBA, you see a normocytic anemia. You get high ESR, which is erythrocyte sedimentation rate. It's just an inflammatory marker. On your peripheral blood smear, you see Rolo bodies. They're collections of red blood cells. I've got pictures of everything later on. That's buzzwordy, Rolo bodies, as is Bence-Jones proteins in your urinalysis, and a pepper pot skull. So you've got bone marrow in your skull as well, and it's kind of, you've got lytic bone lesions all throughout your skull, so it looks like a pepper pot. If they're,
are you doing an X-ray or not?
No, it's you don't do them, but the thing is that occasionally Monash likes to test them. But it's kind of like if you have someone with multiple myeloma, if they've got a skull fracture, you're not going to X-ray it, you're going to CT it. And why would you just normally X-ray someone with multiple myeloma? You just don't. So you don't actually do them, but these are the buzzwords, so it's important to know. Management is stem cell transplant if a young patient aggressive course. You also use CHOP chemotherapy in elderly patients, but it's not a great disease to have. It's pretty disgusting. Hodgkin's lymphoma, so about 15% of lymphomas are painless rubbery lymph nodes, and they become tender after alcohol. Your B symptoms are your classic ones here, but actually in stage 1 Hodgkin's lymphoma, it's asymptomatic, so you pick it up incidentally. On blood film, read Steinberg cells. That's important to note, not just because it's a buzzword, but they are like the hallmark cells of lymphoma. It's got a good prognosis. It's pretty easily cured. Non-Hodgkin's lymphoma is high grade, so there are multiple different types. So you can have high grade, which is aggressive, poor prognosis if untreated. It's like Burkitt's lymphoma and diffuse large B-cell lymphoma, or low grade, so indolent is slower progression, so something like a follicular lymphoma, which is because of the BCL2 translocation. This is probably, I'm going to show them to you, but if you're going to learn them, you're going to learn them in your own time. So I'll just skip through these quickly. So target cells look like a target. Pencil cells are long and thin. They're also called elliptocytes. Joel bodies, so occur in asplenism, and they're little DNA microinclusions. Heinz bodies, I can't remember exactly what they are, but they're in G6PD deficiency. They're pathognomonic for that, as are bite cells. So it's like literally a little bite taken out of the cell. Spur cells have longer, thinner spurs. They're also called acanthocytes, and they're an alcoholic liver disease. Burr cells are kind of nodular, so you can get them in uremia and liver disease, but they can also just be from the collection process. Rolo bodies is what I talked about earlier. So you see how you've got like these, the red blood cells are glutinate because of the overproduction of antibodies. It's kind of just like in a Coombs test, apart from it's in your blood, which isn't as fun. And that's multiple myeloma. Reed-Steinberg cells, so this big cell here is a Reed-Steinberg cell, and then they call them that because they're not actually sure if they're like B cell or T cell. They're kind of somewhere in between. And they're Hodgkin's lymphoma. Smear or smudge cells, so CLL, and you see they've literally just been ruptured and their contents are everywhere. These are ore rods, so they're these little inclusions here, and they actually look like rods. And that's in AML, and teardrop cells in primary myelofibrosis, so they look like a tear. It's probably more important for you to recognize the name than the appearance, as most of them look like what they are. They look like what they sound like, and you're unlikely to get a blood smear in your exam, but it would suck if I was proved wrong. Which one of these statements is true concerning von Willebrand factor? You get to pick someone.
Steph Cat.
I don't know where Steph is. Yeah, it's D. So, well done. Von Willebrand causes collagen to cross-link patients. It doesn't carry factor 9, it carries factor 8. And it does form large aggregates, but it's actually cleaved first. So that's another weirdy answer. This is your clotting pathway. It's kind of nice if you know it, but it doesn't really matter if you don't. You can just learn it in words. What will be important is learning these pathways, but there's like a couple of easy ways to remember. But what happens with clotting is like you get injury. So blood vessels severed, for example, and then you have vascular spasms. So up until that point, the vascular smooth muscle contracts, so it reduces the blood that comes out. Then you get a platelet plug formation. So platelets are activated by broken collagen and chemicals from the injured endothelium, but also when that blood hits the outside, it very quickly, I'm trying to remember the words and I can't. It triggers the extrinsic pathway because extracellular contents contain, extravascular contents contain that, and that travels back up through the blood to activate platelets as well. And those platelets bind to the tissue wall and activate other platelets, which binds to the tissue wall. Von Willebrand factor is key. It's released from the endothelium and from the platelets, encourages collagen binding to those platelets. And then you get coagulation. So fibrinogen is converted to fibrin by the clotting cascade. It forms a net to trap more platelets and RBCs, which is a clot. That's kind of all you need to know about it. The intrinsic pathway is measured by your APTT, and I like the way that you remember the first letter of the next one by the last letter of the first one. So 12, 11, 9, 8, 10. So yeah, yeah, I'm sure you get that. It's activated by exposure to the subendothelial cartilage. So it's caused by in-vessel injury. Just to go through that, E and 11, N and 9, E and 8, T and 10 seem to blow a few people's minds. Your intrinsic pathway, you just remember it's 7. I know, you start to remember after a while. It's more potent than the extrinsic pathway because obviously if blood's like hitting something outside the vessel, it's bad. Tissue factor 3 is normally expressed by cells surrounding the blood vessels. Trauma to the blood vessels exposes tissue factor and activates this pathway, and it's caused by blood exiting the vascular space. Calcium, ionized calcium is really important for both pathways. And the common pathway, as we saw here, begins at factor 10. So your intrinsic is just factor 7. your extrinsics, your 12, 11, 9, 10, and then 8's involved in helping 10. 8, 10, sorry. Jeez, I got that wrong. All right, coagulation. So PT is your prothrombin time. It relies on the extrinsic pathway. So particularly factor 7. It's hugely factor 7 dependent. It's usually reported as an INR, which is your international normalized ratio. It reports how long it takes for a patient to clot in relation to the international median, essentially. It's so like your INR in Australia is the same as your INR in America for people taking warfarin. APTT is your activated partial thromboplastin time. TT for table tennis, so it's inside, so it's the intrinsic pathway. These are all the things that I know I got taught, and most of them I still remember, so they work. And then you can use mixing studies. So if you've got an increased PT or APTT, what you kind of do is you replace some factors, and then you see, and then if those factors are replaced and you still have a prolonged clotting time, it means it's not due to a deficiency of those factors, it's due to an inhibition of the whole system. Whereas if you replace the factors and it corrects, it means that the initial prolong in APTT was due to those factors being low. So your prolonged PT is warfarin, vitamin K deficiency, liver disease, factor 7 deficiency, and DIC. And a prolonged APTT is heparin, liver disease, hemophilia, von Willebrand's disease, and DIC. If you get a PT and APTT, it can be a combined factor deficiency. It can be the deficiency in factor 1, 2, 5, or 10. It can be due to liver disease, severe vitamin K deficiency, super therapeutic doses of your anticoagulants, so your warfarin, warfarin or heparin, DOACs, or bridging warfarin with heparin. DOACs and NOACs, they're the same thing, but different people refer to them as different ones. DOAC just stands for direct oral anticoagulant. Was it Steph's? Steph's, choose someone. Good luck, Nick. Crack a guess. A is completely correct. Not bad. So hemophilia, so it's always X-linked recessive. Hemophilia A is a factor 8 deficiency, and it's sort of divvied into the 3, less than 1% is severe, 1 to 5 is moderate, 5 to 40 is mild. Hemophilia B is a factor 9 deficiency, same sort of thing, it's usually less severe. Symptoms, you get hemarthrosis, so bleeding into your joint space, and that's bad. That dissolves the cartilage, causes massive amounts of actual arthrosis. But more commonly, easy bruising and blood noses are kind of giveaway features of hemophilia. Von Willebrand's disease, so you get easy bruising and bleeding, nose and gum bleeds, and that's because of a decrease of von Willebrand factor. So it actually is an effective factor 8 deficiency, because factor 8 deficiency has a tiny half-life, and to supplement that, the body has it carried by von Willebrand factor, which increases its half-life massively. Acquired liver disease, so if you get liver disease, a vitamin K deficiency, or things that decrease the absorption of fat, so choledocholithiasis, pancreatic insufficiency, severe Crohn's, or DIC, they all cause bleeding disorders. Yeah. So something I want to talk about very quickly is your PT. No, I'll talk about it with warfarin, actually. Hypercoagulable disorders. So congenital factor V Leiden is the only one you care about. Acquired TTP, HITS, and DIC. Heparin-induced thrombocytopenic syndrome, they might test only because you've had a lecture on it. Wait, have you guys done your anticoagulant drugs lecture? Yes. Okay. All right, choose someone else for the factor V Leiden question. Really sorry, I forgot your name, but should. Good luck, Tom. Yeah, so we had this question last year, and I don't actually know the answer for this. Jesus, mate, that was brutal. Sorry, I don't actually remember the answers. Essentially, the thing is you can't give estrogen to someone with factor V lead-in because both of those are prothrombotic. So they both increase your risk of DVTs and PEs. So a progesterone-only pill is completely safe. The other thing is a depot injection's pretty good. Because the progesterone-only pill, like it's only newer evidence, but depot does not cause this sort of it doesn't cause prothrombotic. So arterial and venous clots. So arterial, they form at the site of an atherosclerosis. So when a plaque ruptures, you get like a kind of arterial. It's like really platelet dense with a bit of fibrin, and it forms up. And either that includes the entire artery, or a bit flicks off, and it like kind of includes a smaller artery. That's what happens in a heart attack. They're platelet rich. They're called white thrombi, and you manage them with antiplatelets, so aspirin and clopidogrel. Venous is to do with Virchow's triad, so they're fibrin rich, they're red thrombi, and you manage with anticoagulants, so warfarin, heparin, DOACs. In reality, all of them are a bit platelet rich, a bit fibrin rich, but like these are older ways of thinking about them, which you might get tested on. DVT, so really important to know Virchow's triad, which are risk factors. So normal blood flow, so stasis or turbulence, hypercoagulability or endothelial injury. Periods of stasis, so hospitalization, flights or long car trips, vascular injury, so surgery, hypercoagulability, so smoking, oral contraceptive pill with estrogen, cancer or factor V lead-in, they're all risk factors for getting a DVT. And you'll always have those sort of buzzwordy type risk factors on a question about it. And then for drugs, just keep powering through. Unfractionated heparin, so it increases the effects of antithrombin on F2 and F10. It also slightly affects F9, F11, F12. It affects the intrinsic pathway, so it requires APTT monitoring, and it's got a reversal agent, protamine sulfate. The only real times it's used nowadays is in an IV infusion for pulmonary thromboembolus or myocardial infarction. And both low molecular weight heparin and unfractionated can cause a heparin thrombocytopenia, but it's more likely to be caused by unfractionated heparin. Mild is transient and involves like you lose 25% of your platelets. And, well, you can lose more, sorry. I think I meant to say 25% of patients. So, yeah, see what I mean about spelling. I'll fix all these up, I hope. Severe involves antibody formation and is rare. It causes arterial clots and strokes. I think I've got a question on it later on, so I'll give that away. Your low molecular weight heparin, so your brand name, or your generic name enoxaparin is the classic one. So it's much more selective for F10. So I've got this little diagram which demonstrates the difference between them. It's irreversible. It used to be used as a bridge for warfarin, and a lot of people say it still is, but it's not actually necessary. It increases risk of bleeding without decreasing your risk of VTE. So its current recommendation isn't that you use heparin to bridge. Use subcut administration, so it's got to be injected. You can't take it orally, and it can be used long-term or hospital. It can be used long-term or in a hospital for DVT prophylaxis, and it can use therapeutically to resolve DVT. Interestingly, unfractionated heparin was discovered by a second year, so look at yourselves. Warfarin affects the extrinsic pathway, which is factor 7, and then it goes into factor 10, which is the common pathway. Factor 7 has the shortest biological half-life, and so it's the first to be decreased in the serum. What that means is the PT time, and therefore your INR, is very factor 7 dependent. In the first couple of days of giving warfarin, your INR raises very quickly, but then it doesn't actually reflect your thrombotic status. You're actually a tiny bit prothrombotic in the first 24 hours. So you actually have to only after you use it for dosing, but the dosing in the first 7 days is different to the dosing afterwards, just because factor 7 makes your INR unreliable in that first couple of days. It's a vitamin K reductase inhibitor, so vitamin K is reduced twice before it can be used by the liver to help create these enzymes, which is 2, 7, 9, and 10, which is your TV channels. 2 is the ABC. I didn't know that. Fun fact. And they're all dependent on vitamin K for synthesis. It requires INR monitoring, 2 to 3 in normal patients, which they might be on it for AF, a prothrombotic disorder, a history of DVTs. You aim at 2.5 to 3.5 in a mechanical, so a metal heart valve. Important points, you need the same amount of dietary vitamin K to maintain your warfarin level, otherwise your INR flips and flops a bit. You reduce or stop ethanol. Not a lot of people actually do, but you need constant amounts of alcohol, like the same amount of alcohol as opposed to constant alcohol to maintain your same INR. Vitamin K can be given as an antidote. It reduces the effect of warfarin. It's teratogenic, so you can't be given in pregnancy, and it's metabolized by CYP450. So the effect of warfarin and the INR are increased by amiodarone because it's a CYP450 inhibitor. I haven't gone into the other CYP450 inhibitors. I can't remember whether it's this exam or the VIA, but we got a question on amiodarone and INR. So you might have the same question. DOACs, they're oral, they're once or twice daily. They're no monitoring required, but they're difficult to reverse. There's a couple of reversal agents out now, but they're expensive and need to be given often. Rivaroxaban and apixaban are factor 10A inhibitors, and dabigatran, it's a thrombin inhibitor, I think. It's factor 2A inhibitor. Nice to know about these is you can't use them in mechanical heart valves, but you can use them in AF. That's what the evidence is about them. Antiplatelets, so aspirin's a non-selective COX inhibitor. In low doses, it selectively inhibits COX-1 and therefore thromboxane's formation, so TXA2, and that's important in platelet aggregations to stop aggregation. It's non-reversible, so once a platelet's been conked out by aspirin, it's conked out for the rest of its life, which isn't that long. But long-term use in the elderly increases your risk of rupturing peptic ulcer. So often there's a history of NSAID or aspirin use in people who come in with a bleeding peptic ulcer. Clopidogrel is your newer antiplatelet, inhibits the ADP receptor on platelets, and that reduces their binding capacity. It's a pro-drug, so you can have errors of metabolism which reduce your ability to use clopidogrel. Streptokinase isn't really used, but I think it's still taught. It's one-time use because it's derived from bacteria and it activates plasminogen. So antibodies can develop and cause allergic reaction in future. That's why it's one-time only. Alteplase is recombinant tissue plasminogen activator. So it also activates plasminogen. And plasminogen is very fibrin selective. So it's really good for clots. It's used in AMI, stroke, massive PE. I think it's used in AMI less than 24 hours, stroke less than 6 hours. That's because if you give a thrombolytic after this time, or when there's too much damage to the vessel around the clot, then actually you start to bleed. And particularly with strokes, bleeding into your brain is much worse than a clot in there. Also massive PE, your lungs damage so quickly that if you give a thrombolytic to someone with a PE, then they're going to bleed. That's why you only use it if it's life or death. All right, I have questions, but you can go or we can do questions. I really don't mind. And people can go and I won't care. Yeah, all right, Tom, choose. All right, Maddie. I haven't fixed all of these values. People just walk out if you want to, I really don't mind. No, you can't. So he's had a constant back pain for 3 months. On physical examination, he's got an infection in his right lung base and plain radiograph. So an x-ray of the spine shows multiple lytic lesions of the vertebral bodies. I don't care about his glucose. His kidneys are failing badly. He's got a lot of protein, but normal albumin. So he's got an increased globulin, so an increased antibody level and normal LFTs. All right, so what's the disease? What's the answer? This is a tough one. Yeah.
Multiple myeloma.
Yeah. And so what do you see in the bone?
I see.
Yeah, ECT. Well done. So plasma cells are what are affected in multiple myeloma. They produce the antibodies. The antibodies dissolve. And the plasma cells take over the bone marrow, which causes these lytic lesions. All right, Maddie, do you want to choose someone who's not Tom?
Yeah. Okay. Susie.
All right, Susie. So, 33-year-old woman who's been experiencing low-grade fevers, night sweats, and generalized malaise for the past 2 months. She has non-tender cervical and supraclavicular lymphadenopathy, and they Pardon?
You said non-tender.
And what did you say?
Okay. As you were,
Sorry. On microscopic examination, high magnification, there are occasional CD15 and CD30 plus positive Reed-Steinberg cells, along with large and small lymphocytes and bands of fibrosis. B, Hodgkin's, yeah. So Reed-Steinberg cells in addition to the specific markers. Yeah. Okay, so it's hard because it's a whole mess of information. What I see with this is dull constant back pain and lytic lesions in the spine is multiple myeloma because the plasma cells take over the spine. The fact that his urea and his creatinine, I don't have the values here, but his kidneys are failing. His creatinine is like 5 times what it should be. His total protein's elevated, but his albumin's normal. So they didn't give you the globulin count, but that's elevated. That's your antibodies count. And because there are excess antibodies made in multiple myeloma causes. Oh no, I was just doing that. Okay. And then that thing. Also, you get a little bit of immune impairment because even though you're creating lots of antibodies, you're not creating the right ones. So that's why he's got an infection. Is that okay?
If these said nodules are large mature lymphocytes, would that be correct?
Yeah.
Option B.
Yeah, I know what you mean. Because plasma cells are essentially really mature lymphocytes. I think if they said large mature lymphocytes and there was no plasma cell option, I'd say yes. Obviously, plasma cell is what they're called, so they don't usually describe them as mature lymphocytes. But yeah, no, it's a really good point. Oh, hey, Yushika. 30-year-old woman has had mild fatigue for many years. Examination shows a palpable spleen tip. She's slightly anemic and it's microcytic. She's got a normal platelet and white blood cell count, but an increased reticulocyte count. Her peripheral blood smear shows red blood cells that lack central power. What of the following patterns of inheritance is most likely with her disease? Oh, I think this is really mean, actually. All right, Yushi, what do you think? B. A is actually correct. Now, this is hard because small RBCs that lack central power is usually hyperchromic. I got this off a website and yeah. Not Wikipedia, but it's actually, so the disease is actually hereditary spherocytosis. So that's a good question. Look, the thing is, I don't think thalassaemia, beta thalassaemia doesn't fit with any of these ancestries. So you'd expect to see a Mediterranean or Greek ancestry with beta thalassaemia. Alpha thalassaemia. This doesn't look like alpha thalassaemia. The other thing is also, so it's alpha thalassaemia not normally tested on, but it's autosomal recessive and you'd think West African, right? It is Southeast Asian, yeah. No, so there's a variant of it in Africa, which is where you get the 0000. Yep. No.
Safia wants to know why is microcytosis a spherocytosis?
So remember, remember like remember our acronym for microcytosis, which is TAILS. So thalassaemia, anemia of chronic disease, iron deficiency, lead poisoning, and spherocytosis. Sideroblastic. Oh shit. All right, you know what we're gonna do? We're gonna ignore this question because it's really punishing me. You want to choose someone else? All right, Izzy, what do you think? B, yeah, it's AML. It's our rods is the buzzword. Any challenges? Sorry. Getting arrogant. Fun? Oh. Izzy, who's next? Oh, give me a sec. He has, sorry, I don't have references. Hemoglobin's low, hematocrit's low. That's actually, medium cell volume's normal. His platelets are normal, white bloods are normal. Serum iron is actually increased. No, it's not, it's decreased. And I think total iron binding capacity is decreased as well. Okay, but this is one of the ones where if you don't recognize the other answers, it's probably the one you do recognize. That's so mean. Okay, so I'll tell you that. So it's a normocytic anemia. Okay, so what's our cause of normocytic anemias? HIBRA, right? So HIBRA. But what's the normocytic anemia that might have an effect on your iron stores? Anemia of chronic disease. Okay, SLE is a chronic disease, but it actually causes an autoimmune anemia because SLE is an autoimmune condition. So which of those is a chronic disease which causes lots of inflammation? B, yeah, it's hepatitis C infection. Okay, so it's a more difficult one, but you have to think through it. Yeah, the other thing is, pardon? Oh. So not necessarily. Hep C doesn't cause a massive raise in your white blood cell count, and also it's a chronic infection. So you don't have it's not a chronic high white blood cell count. It's just like it's underlying low levels of infection, but the body recognizes it has inflammation happening. That's a fair point, though. Yeah.
I have a question, but I'm not sure about this. So Hep C infections are also caused liver damage,
Yeah.
would that lead more likely to a macrocytic anemia?
So,
In that case, we just suspect diverticulitis instead.
diverticulitis is not as much of an inflammatory disease. So diverticulitis is an acute inflammatory condition, which is unlikely to, unless there's lots of bleeding, cause an anemia. Hepatitis C, so something they don't really say is that the liver actually retains its synthetic function for a long, long time. And so it's got to be fairly cirrhosed. So they're all like that. It's a good point, and it was a good point before. It's the most likely answer. So yeah, Hep C infection. What do we think about this? Tushar, do you want to choose someone?
Shiva.
Just to call her out for sitting by us. All right, I'll give you a clue. 3,000 gram spleen size is like, it's truly massive. Yeah, hey, myelofibrosis. So yeah, sickle cell, your spleen becomes a lot smaller. In portal hypertension, the spleen becomes it becomes slightly bigger, but it's nowhere near three kilos. It's also wouldn't present like this. You have to look for the other symptoms of portal hypertension. Infectious mononucleosis, like you might get slightly enlarged, slightly tender, but not massively enlarged, and its EBV only lasts a few weeks. And hemochromatosis, you wouldn't get a massive enlargement. You'd also like have something about iron stores, probably. Do you want to choose someone? Was everyone okay with that question? Cheers, Tom. I'll just go through these quickly. Your white blood cell count is heightened, so significantly heightened. But 16 segs means neutrophils, so the only one you're really concerned about here is your lymphocytes, which are massively enlarged. You've got a normocytic anemia and normal platelets with a positive direct Coombs test. Disregard the Coombs test because that's a rarity. Pardon? Yeah, D. So it's chronic lymphocytic leukemia. Okay, and so like most of the cells are lymphocytes, which are circulating. It also fits, it's the right age group. And you can get like things infiltrating the spleen and liver. It's not really that important to know about, but hepatosplenomegaly slight is one of the CLL symptoms. All right, is everyone happy with that question? All right, Tony, pick someone else. Good luck, man. Hemoglobin's super low. It's microcytic. Platelets are normal. White blood cells are normal. I think ferritin's normal. I can't remember. It's normal. A bone marrow biopsy is performed in myeloid erythroid. Your normal myeloid erythroid ratio is 2:1. Oh no, sorry, ferritin's high. Ferritin's very high. Going for D? Oh, sorry, man. I know it was the answer for the last question. That looked a bit dodgy. So it's beta thal. So what you've got is you've got a really microcytic anemia. So the microcytosis is, well, it's actually fairly normal. It's like fairly in line with the hemoglobin, but it's actually super microcytic. Everything else is normal, and it's also, you know, it's hereditary and it's a 16-year-old boy. The other thing is, like I said before, beta thalassaemia can cause hemochromatosis, or at least iron overload. So it's a tough one, but that's it. Hereditary spherocytosis is a good second guess though. Yeah.
What's the myeloid
Oh, it's so in your bone marrow you have myeloid cells, and so you have myeloid precursors and erythroid precursors, right? And so normally you have a 2-to-1 myeloid to erythroid precursor, and Monash doesn't teach it, so they're not going to include it in one of their questions. I think that's a better bit of information. Okay, I'll talk you through this one, but you get to choose someone. Christian. All right, so 83-year-old woman breaks and falls her left wrist. She has an operation to fix it, and she gets heparin afterwards. So admission. So she's not anemic. Her platelet count's normal. Her white blood cells are normal. Her prothrombin and PTT. So her prothrombin time's normal, but her PTT's lowered, and that, yeah, I won't say anything about that. 1 week later, so then her hemoglobin's the same, her hematocrit's the same, her MCV is the same, so that's all good. Her platelet count is half, and it is low. Her white blood count's essentially the same. Her prothrombin time's essentially the same, and her PTT is essentially the same. And then suddenly she stops being able to move her right arm, and I'm going to say she has quite a lot of pain in it. So what's the most likely cause? There's only one cause we've talked about, but it's kind of hidden. Yeah, that's perfect. Heparin-induced thrombocytosis. Really well done. Anyone? Oh yeah, I'm just going to assume you're okay unless someone yells at me that I'm wrong again. All right, who's next? All right, 48-year-old man, increasing malaise, difficulty concentrating. So hemoglobin's slightly low, hematocrit's slightly low, MCV is normal, platelet count's normal, white blood cell count is hugely elevated, and you've got lots of neutrophils and lots of whatever bands are. It's just like not like huge amounts, but just like slightly elevated. Yeah. And then you've got all these like myelocytic cells. Don't care about the LAP. And what are you going to see in your biopsy? All right, I've heard like a C. Yeah, it is C. So he actually has CML, and because you've got like a indolent, sort of slow-going, progressive myelogenous leukemia, you're getting all these myeloid cells, which are kind of happening. Oh yeah. So ignore. Do you want to choose someone? All right, you've gotten the easiest question so far. Ignore the first bit. Which of the following conditions is most likely to be found in a person without a history of drug ingestion? That's all right. Sorry, I kind of put a lot of pressure on you there. What's the most common anemia? How does that? What type of anemia is that? Yeah, sorry. It's hard. You've got to look for them like described in a different way, because that's like a lot of these are so buzzwordy. It's the only way you can get around it. All the others can be brought on by drugs. Okay. Do you want to choose someone?
Whoever's at the very back.
Wait, sit down. All right. What do you think? A? Yeah, because anti-malarial is usually quinine or doxycycline. We're going to know doxycycline and assume it's quinine, which is the most common thing to bring on G6PD deficiency. Nice. All right, do you want to choose someone? All right, let's have a look. Hemoglobin's low, MCV is really high, platelets are normal, white blood cells are normal. What are you going to see? A, yep, so it's a megaloblastic anemia. Well, we know it's macrocytic, but it makes sense that it would be megaloblastic and hypersegmented neutrophils. So nice. All right, who are you going to choose? Yeah. Yes. Yes. Oh, they're not as common a finding as hypersegmented neutrophils. No, that's a really fair point, actually. Megaloblastic is nuclear, yeah. That's genuinely an oversight, I'm sorry. So yeah, B is a correct answer as well. I'll change that. All right, can you choose someone, please? Nice to meet you, Jordan. The hemoglobin's low, MCV is low, platelets and white blood cells are normal. Oh, I don't know percentages. Let's say the white blood cell thing's normal, bilirubin's normal. Hi, Susie. Yeah, C. Iron deficiency. All right, choose someone, and this is the last question. So sucks if you get this one wrong. Sucks if I get it wrong. Oh no, this is really hard. I put this in for my interest. I won't make you answer that. Okay, so this is Southeast Asian. So what's the thing I got very rightly corrected about it being a risk factor for? Alpha thal. Yeah, so hematocrit is 17%. So that's hugely low. and nucleated red blood cells and erythroblasts. So just essentially the marrow is just not able to do its job, and the red blood cells just look really fucked up. So what is the most likely disease to cause that? Yeah, it's alpha thal. Yeah, this case was actually a 0000, so the baby died very quickly after. But yeah, all right, that's the lecture. Nice, cheers, man. That is fucking tricky.
Yeah, it's pretty cool.